All right, guys, can you hear me? We might start now. So if you don't know, my name's Mark. I'm one of the third years, and today I'll just give you a quick, hopefully it won't be too long, just a quick talk on your Year 2 Haematology. So the things... Oh, fuck. All good. So the things we'll go through, we'll briefly cover basic like red and white cell physiology, and then we'll go through some anemia, which is quite an important topic. Transfusion medicine isn't too big. We'll have a look at some blood films. Heme malignancies is a reasonably big topic, and then clotting is pretty important to know. So I think for the past couple of years, heme has been a reasonable amount of your mid-semester exam, but I think the content isn't too bad. So if you sort of can get your head around it, I think this should serve you well, but I would definitely spend more time trying to understand reproductive physiology, because I could never really get my head around that, and I'm sure you guys might feel the same way. So let's get started. So this picture, I feel, is a really good sort of start for hematology. So with every single blood cell, you begin from a hematopoietic stem cell here, and all your hematopoiesis occurs in bone marrow. So you have myeloid and lymphoid lineages, in a sense, and it's really important to understand sort of which of the cells arise from the myeloid lineage and which cells arise from the lymphoid lineage. So I have this up again at a later stage where we talk about hematological malignancies, because it's even more pertinent then. But so I'll just quickly go through. So do you guys all know what like basophils, neutrophils, eosinophils, and like mast cells do? Do you want me to go through that quickly, or are you guys all comfortable with that? Yeah? Okay, I won't go through it then. But just know that red cells are from the myeloid lineage, and also all your... is this an innate or adaptive? I don't know. But anyway, one of them, one of the immunity, I never really paid attention in those microbiology lectures. So one side is from the myeloid and one side is from the lymphoid. So lymphoid is a bit easier to remember because you have the lymphocytes, which are lymphoid, so it's a bit easy to remember. Okay, so we'll begin with red blood cells. So you guys should all know that red blood cells have a biconcave disc shape. It helps them to get through blood vessels. It's important to know that they're anucleate, and that it's essentially a sac for all your hemoglobin, which is the primary way your body transports oxygen around the body. So hemoglobin contains 4 globin units, and these globin units also embedded within them have a heme unit with iron. So that's why when you don't have iron, you have trouble, you have like symptoms of hypoxia in a sense, which I'll go through a bit more in detail later. So with erythropoiesis, again, all your hematopoiesis only occurs in bone marrow, pretty much. They live for 120 days, you should know this. Reticulocytes, have you come across the concept of reticulocytes? So these are just immature red blood cells, and if you look at the amount of reticulocytes in your body, it can give you an idea of whether or not your red blood cell function is impaired, or whether or not you have a sort of secondary pathology which is causing an increase in the production of red blood cells. And it's regulated by EPO, primarily produced in the kidneys. And with your white blood cells, again, from the bone marrow, all your lymphocytic origin ones, mostly just think lymphocytes and lymphocytic, it's pretty simple. So B lymphocytes mature in the bone marrow, and T lymphocytes in the thymus, so T for T and B for B. And the platelets are produced by the megakaryocytes. So if we go back here, the megakaryocytes produce the thrombocytes, which are essentially the platelets. So I've got a question. How do you guys want to do it? Do you just want to work it out amongst yourselves, or do you want me to sort of pick on one of you, or should I call names of people I know? Theo? D? And why would you say that? Yeah, okay, it's pretty simple. And then the next question, anyone want to shout it out, or do you guys just want to sort of work it out amongst yourselves and then I'll just go through it? Does anyone have any ideas? A? Did you say A? Yeah. Do you know why? Pardon? Sorry, I couldn't hear you, but I think you said something about the gamma chain in the fetus. Yeah, that's correct. So the fetal hemoglobin isn't affected by DPG. So if you look at the oxygen hemoglobin dissociation curve, essentially because the fetal hemoglobin isn't affected by DPG, you get left shift, so you get more tendency of the red blood cells of the hemoglobin is to hold on to the oxygen. So I don't really know how important this is regarding hematology, but it's been in the last 2 years revision lectures, so I thought I might just pop it in anyway. So we'll go through hemoglobin now. So in adults, you have so in adults, you have 2 alpha and 2 beta globins, right? Because I mentioned before there's 4 globin chains which form the sort of framework of your hemoglobins. So in adults, primarily, it's alpha and beta, and in some cases, this is quite normal, you get alpha and delta. So you always have alpha, and sometimes there's a little bit of delta. However, in the fetus, you have gamma, and the gamma, as I said before, isn't affected by DPG, so it has a higher affinity to bind oxygen. And after birth, about 7 to 8 months or thereabouts, they start to sort of switch over, so you get more gamma, you get less gamma production and more beta production until it completely switches over. And it's also important to note that hemoglobin either carries 0 or it carries oxygen molecules on all of its binding sites. So when someone says there's, I don't know, like 75% hemoglobin saturation, that doesn't mean that 3 oxygen molecules are bound to hemoglobin. It means that 75% of the hemoglobin have 4 oxygen molecules bound to it. Does that make sense? Cool. So again, a bit of revision, I suppose. Oxygen dissociation curve. What does a decrease in pH do? Hope you guys all know this from your RESP. Does anyone want to shout it out? Yep, and it's all from the graph before, so as long as you can memorize the graph and draw it out, you should be good. Yeah, so this is quite an important area of hematology, so both for your exams and just for all future practice. So FBEs, or full blood examinations, probably the most ordered blood tests in hospital or in a GP clinic. So I'll sort of run through it systematically with you guys. So for any investigation, the first thing you want to do is you want to see if it's the right person's investigation. So you want to see, it doesn't say here, but it should say, oh, so-and-so's like UR code or this person's FBE. Because if you're looking at the wrong person's FBE, you're going to look like an idiot. And then you want to look at when the FBE is from or when the investigation is from, because there's no point seeing that a patient is anemic 4 years ago when you want to see if they're anemic now. So obviously this isn't the best example, but just keep that in mind for any. So like X-rays, especially, you want to look to see the date and also the patient details are correct. And then from there, you want to look at hemoglobin first. So you don't need to remember the reference ranges at all because they'll give them to you in the exam. And in real life, you sort of, once you've seen enough, you kind of have an idea what the ranges are anyway. So if the hemoglobin is below the reference ranges, then they're anemic. It's simple as that. And then white cell count just tells you whether or not they've got an infection. So if it's raised, it's more indicative that they have some sort of infection, probably bacterial. And then your platelet count, it's part of this concept called acute phase reactants. Have you guys heard of this concept before? So during acute inflammatory states, certain things in your body will go up and certain things in your body will go down. So platelets will go up in acute inflammatory states. Do you guys know anything else that might go up in an acute inflammatory state? So have you guys heard of tests like CRP, like C-reactive protein, ESR, ferritin goes up as well. And then you can also have like negative acute phase reactants. So these things tend to go downwards in acute inflammatory states. So I think from the top of my head, albumin is a negative, but don't quote me on it, but I think it is. So these are probably the most important three things to look at. And then from there, especially if they are anemic, you want to look at their MCV. So the MCV stands for mean corpuscular volume. So it just indicates to you the average size of each individual red cell. So if the MCV is lower than the reference range, it shows that the average size of the red cells is lower than normal, they're smaller than normal. And then if it's in the middle, then it's normal. And if it's higher, then it means it's big. So it gives you your micro, normo, macrocytic anemias. And then your MCH, it's probably not as important because if you're microcytic, you're normally hypochromic and they usually just go hand in hand. Except for macrocytic, you can't really get macrocytic hypochromic that often, I don't think. But MCH isn't as important to look at, but just know what it means. It just indicates to you the amount of hemoglobin in each individual red cell, like the average. Yeah, good so far? All right. So with anemia, it's just simply a lowered hemoglobin concentration in the blood. And it's important to note that it's not a diagnosis by itself, and you need to find out what's causing the anemia, and you have to treat the cause for the anemia to go away. So this is just a general reference range. You don't really need to commit that to memory. And as I said before, there are three broad categories. So you have microcytic, normocytic, and macrocytic. And that's determined by your mean corpuscular volume. So if you just look at that in an FB, it will just tell you. So it's pretty simple. So with anemia, you get the classic signs and symptoms, very non-specific signs like fatigue, exhaustion, general just weakness, shortness of breath. These are some signs. So conjunctival pallor is probably a really good sign. I'll show you a picture later, but I'm sure in your OSCEs and clinical exams, you always talk about oh, I'm looking for conjunctival pallor and blah, blah, blah. So yeah, it's actually quite important. It's a big sign of anemia. Pallor of palmar creases. And then if your anemia is really bad and uncontrolled, you can even get cardiac symptoms like palpitations, exacerbated angina, and even flow murmurs and things like that. It's a bit in depth, but yeah, so just know that it's a good idea to always try and treat anemia when it presents because it can get quite worse. So just beginning with some of the microcytic anemias. Hang on, did I skip a slide? Oh, okay. So this slide, I've pretty much taken this from last year's revision lecture with permission. And pretty much if you can remember the acronyms, it will help you a lot to remember some of the causes of micro, normo, and macrocytic anemia. So the ones I've highlighted are probably the more important ones to sort of remember. So especially for microcytic, and if you're in an OSCE and they give you an FBE to look at, and you say something like, oh, they have microcytic anemia, might be lead poisoning, the examiner's going to look at you and be like, why didn't you say iron deficiency? So don't do that, please. So remember for microcytic, it's pretty much always iron deficiency, and thalassemia can be another differential, and these are quite rare. And then for your normocytic, it's more likely to be either renal failure or just like a sudden episode of like massive bleeding or hemolytic anemia. Those are probably the three more common ones. And with macrocytic, the two to remember, if you can't remember anything else, is B12 and folate. Those are probably the most important ones. And then with your endo stuff, hypothyroidism sort of fits in there, and it can cause macrocytic anemia as well. So these acronyms are a way I use to sort of help me remember the causes of all the anemias. So I think if you guys can remember the acronyms, then you should be pretty good for exams. Also, here I've sort of noted that when someone says they have megaloblastic anemia, it only refers to B12 or folate because they affect the actual DNA production in red blood cells. So just keep that in mind. So we went through this before. So I'll just begin with thalassemia. So I haven't gone through alpha thalassemia that much because I don't really think it's that important or that exam relevant or even that important in real life because it's so rare. But just know that it's most common in Southeast Asians, so A for Asians, and and that there are 4 alleles that are responsible, whereas in beta thalassemia it's 2 alleles. So beta thalassemia is by far more common than alpha thalassemia. So if someone presents with thalassemia, just think it's beta, unless like they're Asian. So it's an autosomal recessive condition, and the problem is with the alpha and beta like globin chain. So you know how they form the framework of the hemoglobin, which carries your oxygen around. So because there's a problem there, it impairs the oxygen sort of carrying potential of your hemoglobin. So there's 3 sort of different severities. You don't really need to know it in that much detail, but just know that beta thal minor is, so minor, intermediate, and major. It's pretty like straightforward. Just think of it like what the names mean. So minor, it's not that bad. Intermediate, it's moderately bad, and major, it's like really bad. So also it like correlates to the amount of gene defects you have. So in minor, you have less gene defects than major, which has really bad like gene defects. So yeah, so I won't go through it any more than that, but just that's sort of a basic overview. So for your thalassemia, probably the first investigation you'd do is FBE, because they're going to present non-specifically with like tiredness and fatigue or something like that. So you're always going to do an FBE first. So something that differentiates thalassemia from iron deficiency is hemoglobin and MCV are both low because it's a microcytic anemia, but your MCV is significantly lower in proportion to the reference ranges. So maybe your hemoglobin's like 80 and your MCV is like, I don't know, I'm making this up, but like 10. So it's like really out of proportion, whereas in iron deficiency, your hemoglobin and MCV will both be like, if it's like mild, it would both be close to the lower ends of the reference ranges. So that's sort of a clue to help you. But if you want more specific sort of investigations targeting thalassemia, just remember, you sort of just have to rote learn this, but hemoglobin electrophoresis is for thalassemia B, and DNA PCR is thalassemia A. And I'm not really sure how clinically relevant this is, but like I've never seen someone take an X-ray of someone's skull for something other than like a blunt force like injury or something. So you have an X-ray of a skull, and I'll show you a picture in the next slide, and there's this Heron end appearance. It's quite unique, and that's present in beta thalassemia major. And then in your blood film, you have these things called target cells and teardrop cells. So you can see here, see how that looks like the target sign? Yeah? and then that's like a teardrop. So these can appear in thalassemia like blood films. So the way you treat it is you have to give them regular blood transfusions because their hemoglobin is like not functioning properly. So you need to get like essentially good hemoglobin to replace it. However, a problem with that is because they need so many, or especially in beta thal major, they will need so many blood transfusions that they can get really iron overloaded. And so you'll need iron chelators, such as desferrioxamine, to sort of lower the levels of iron, because too much iron can be really bad for you as well. Yep. So this is the Heron end appearance. So you can sort of see how, if you look at it, there's like hair sort of standing up, especially up here, and like across down here. But I've never seen this like in real life, so yeah. So with iron deficiency, so iron is absorbed in the duodenum. So some of the causes, if you think about iron being absorbed in the duodenum, you can sort of imagine the causes apart from poor diet, which is pretty obvious, so not eating enough red meat. So because it's absorbed in the duodenum, any sort of surgical procedure or any condition or inflammatory bowel condition or anything affecting the duodenum can cause iron deficiency because you're impairing the uptake of your iron. So people with, do you guys know what celiac is and what it does? So pretty much it's just a condition where you have, is like basically inflammation of the mucosa in a way, and it affects the absorption of lots of things, and iron is one of them. And if you have a gastrectomy, so like if a surgeon takes part of your bowel out because you have a cancer there, then it will also affect your ability to absorb things. Also, another important cause of iron deficiency is chronic blood loss. So people with cancers, people with like colorectal cancer, people with like menorrhagia, people with like gastric cancers, which are just constantly bleeding but slowly bleeding, and it's very occult and they don't really notice, and then they just present with like tiredness. Think iron deficiency straight away. So some of the signs you can get, so koilonychia, I've never seen this either, but just know that it's the spoon-shaped nails. Glossitis, angular cheilitis. I'm sure there's like a whole list in tallies you can refer to. And then this is conjunctival pallor. So you can see here how the entire conjunctiva is pale. So in a normal person, there's usually a line halfway here. I should have included a picture. I can, in the slides that I upload later, I'll probably include a picture for your reference. But there's usually a line here which sort of demarcates the pale area from the red area. So in a normal person, if you guys look at each other, there should be an area of redness in front anteriorly, and then there should be a pale area posteriorly, and that's completely normal. However, if you lose this line of demarcation, then it all becomes pale, and it's conjunctival pallor. Yeah? So now you guys like sort of know what to look for in your OSCEs. So with the investigations, again, you do an FBE first line. MCV and hemoglobin tend to decrease in parallel as opposed to thalassemia. And as I talked before, platelets are an acute phase reactant, so they'll go up acutely in stages of inflammatory or like acute like conditions. So iron deficiency is one of them. So the way you treat it, depending on the cause and things like that, but usually you just go up the like a scale sort of. So you first give them iron orally, and if that doesn't help, you give them iron like intramuscularly or IV, I think, and then you can give them blood transfusions, and then if they're really bad, you can give them EPO. And then again, if you give them too much iron or they have iron toxicity, you have to treat with desferrioxamine. So iron studies is kind of confusing, so I'll quickly run through what these all mean, and then I'll give you guys a chance to sort of try and work out these, and then I'll sort of talk you through them in about, I don't know, 3 or 4 minutes. So serum iron is the amount of unbound iron in the bloodstream. Yeah? Ferritin is sort of a molecule which stores iron intracellularly for you. So it's the amount of iron storage you have. Transferrin is a protein which binds iron in the bloodstream and transports it from different sorts of cells to other cells where it's required. And total iron binding capacity is the propensity for iron to bind. Yeah? So do you guys want to give these a go? Maybe just give the first one a go and I'll talk you through it, and then you guys can go through the next 2 by yourselves, and then I'll talk through it again. Yeah? Also, if you have any questions, feel free to just put your hand up and I'll try and answer it as best as I can anytime. All right, maybe we'll go through the first one now. So the first one is pretty much iron deficiency. So you'd expect your iron to be low, obviously, because you're iron deficient. Your ferritin is low because the stores of your iron are also low, which is causing your iron deficiency. But your transferrin and total iron binding capacity is high because it wants to bind as much of whatever is left over in your bloodstream so you can use it because you're iron deficient. Does that make sense? Are you sure? Yeah? Okay. Do you want to go through the next 2? I'll give you 2 minutes. All right, let's go through the next 2. So in iron overload, it'll just be the exact opposite to iron deficiency, right? Because it's the same physiological principles, but just in reverse. So you have increased iron, increased ferritin, and decreased transferrin and total iron binding capacity because there's already a lot of iron in your bloodstream, so there's no need for it to sort of bind the remainder. Yeah. And then with the last one, it's a bit tricky. So the way I like to work through it, and the way that made sense to me the most, is you're anemic. So AOCD is anemia of chronic disease. So you're anemic, so your iron is low, yeah? But because the chronic, so with a lot of chronic inflammatory processes, a lot of cytokines are released. You don't really need to understand the mechanism, but there is a pathway, and then through the cytokines, the liver produces more hepcidin, and then it encourages iron to be stored intracellularly in ferritin. So that's why your ferritin is high. And because your ferritin is high, your body thinks that, oh, I have enough iron stored up, so my transferrin and total iron binding capacity need to be low, because otherwise I'll go into iron overload. Yeah? All good? If you have any questions, this is quite confusing. I didn't really understand this when it was taught to me last year. If you want me to go through it again or anything, I can do that. So are you guys good? Good with that? Yeah? Good? All right. So if anyone wants to, if you guys just want to have a read through it, and if someone's confident enough to sort of have this, give this a go, and that'd be good. B? Yeah. So it's a pretty stock standard question. So yeah, I'll go through hemochromatosis quickly. I don't think it's particularly core, but it's a good condition to know about if you're learning about iron deficiency already. So it's a condition where you basically have too much iron. So before, when iron overload, it's pretty much just hemochromatosis. And the excess iron can deposit and destroy organs, particularly your pancreas. That's particularly susceptible. So the classic Monash buzzwords are bronze diabetes. So if you look at the question before, the guy had hyperpigmented skin and he had diabetes. Hang on. He had HbA1c of 8%, which is pretty much diagnostic, I think. And then he also has joint pain, so the iron has deposited in the joints, and the you can get joint pain and cardiac problems because the iron can deposit there. So with diagnosing hemochromatosis, it's from iron studies. So just the iron overload slide before, so high ferritin, low transferrin, low total iron binding capacity. And then this is more like pathology next year, but it could be a buzzword. I don't really even know what it is, to be honest, but Pearl's Prussian blue stain, there you go. So treatment, you just need to get them to regularly go and get blood taken out, and then all the excess iron will be taken out with the blood. And you can also use iron chelating agents to further supplement this. So now we'll move on to normocytic anemia. So for me, the best way, or the way that helped me sort of understand the ways it can occur, is to look at the reticulocyte count. So if you have high reticulocytes, it means your body is producing a lot of red blood cells. So it indicates that you've either lost blood somewhere acutely, or your blood is being lysed somewhere, so like hemolysis. Yeah? And if you have low reticulocytes, it means that your body isn't producing a lot of immature red blood cells, which means you have a problem with the production line. So you have a problem with the bone marrow, or you have decreased EPO, or yeah, I don't really get this, but just put it in. Yeah. Cool. So it's important to know, just forget about this. Just know that if you have low reticulocyte count, the bone marrow is affected, so the production center is affected, or you have decreased signals from the kidneys to produce red cells. Yeah? So decreased EPO. So these are some of the things I'll go through quickly. Probably these four are important. That one's just for interest, so I'll just skip that. So with G6PD, it protects your red blood cells from oxidative stress. So when it's lacking, if you eat fava beans, there's things and enzymes inside the fava beans which expose your red blood cells to oxidative stress, so you can get hemolytic anemia. Yeah? and also certain drugs. But you don't really need to know. You don't need to know what drugs. You just need to know that drugs can cause it as well. So on your blood film, you see Heinz bodies. So it's these little things here. And what that is denatured hemoglobin in your red blood cell, because this protects it from oxidative stress and because it's not doing its job. So you can get denatured hemoglobin. And then when the macrophages come around and they get rid of it, you get the bite cells. So these looking things here with a chunk out of them, and then these are your Heinz bodies with the little denatured hemoglobin on the side. With sickle cell anemia, so these are all normocytic anemias, by the way, hemolytic anemias as well. So with sickle cell, it's a hereditary condition where you have a mutation where one of the chromosomes, I think, which produces valine is converted to, you have a valine instead of glutamate. Have you guys heard of the sickle cell trait, I think it's called, where they don't have two alleles, they're like a carrier, so they have like the best of both worlds. Because it's infested with malaria over there in Africa, no, it's the truth. So it's like an adaptive mechanism that they've sort of developed over time. So the sickle cells are immune to malaria. So if they have some sickle cells and some normal cells, that's like most advantageous over in Africa. But if you have two copies of the defective gene, then you have only sickle cell red blood cells, and this is really bad because you can get because they don't function like a normal red blood cell, so they can't move through the vasculature easily. You have sort of clumping, and you can get vaso-occlusion. And then the spleen is particularly susceptible to this, so you can get vaso-occlusion in the spleen, and then you get splenic infarct, and then you get hyposplenism, and then your spleen doesn't work anymore, or it functions at a lower capacity. So on your blood films, you get the sickle-shaped red blood cells like these things, and then how jolly bodies. So these are these things. So it's different. It's different from Heinz bodies because Heinz bodies are on the outside of your red blood cells, and these are inside. And I think these are nucleus. So you know how the red blood cells is normally anucleate? So because your spleen is not functioning properly, the spleen isn't able to sort of sequester and get rid of the like odd like red blood cells, the ones that aren't meant to be there. So the ones with nucleuses can just float around in your bloodstream. So that's why these are present. So yeah, so which of the following would detect an autoimmune hemolytic anemia? See, okay, that's good. So I won't explain direct Coombs and stuff then, because you guys seem pretty on top of that. So with your autoimmune, pretty much just know that positive direct Coombs is diagnostic, and warm occurs at body temperature, and it's warmer, and then cold, which is lower temperature. It's pretty intuitive. And then you have spherocytes in your blood films. So this can sort of guide you. So if they give you a blood film and they're like, oh, what condition could this be? If it's spherocytes, probably this. Yeah? So you guys seem pretty comfortable with direct Coombs, so I won't really go through it, unless one of you wants me to. But probably let's try and speed things up, because you guys have had a pretty long day, I hear. Yeah? We'll move on. So this is probably not as core, but it's good to know. So in some diseases like hemolytic uremic syndrome, thrombotic thrombocytopenic purpura, and DIC. The vessels, the endothelial layer, it gets damaged, and you have clotting, like the clotting pathways activated. So because you have the clotting pathway activated, the blood vessel is narrowed acutely, and then as the red blood cells pass through it, they get fragmented because it's not meant to be there. So they pass through, they get fragmented, and they become these things called schistocytes. So this is what they look like, just fragmented red blood cells. Cool. And don't learn what these are unless you're like really bored and you have a lot of time, because it's not really relevant for second year. But definitely next year you need to know. So yeah. I won't go through this. This is like a bit of optional stuff. So which of the following would you expect a low reticulocyte count? Pardon? D, yeah. So aplastic anemia affects your bone marrow, which is like the production center, so that's why you have low reticulocyte count. So I'll go through it. Okay, another question. Which of the following will not cause aplastic anemia? Yep, so, yep. So the rest of these all cause aplastic anemia. So your causes of aplastic anemia, you have drugs like chloramphenicol, toxins. So I think gold can also cause aplastic anemia. Like gold used as like treatment, like not wearing gold necklaces and shit. So ionizing radiation, obviously toxic. Infections like Hep B and Hep C, I think, can cause it. And if you have a genetic predisposition, you can also get aplastic anemia. So what happens is pretty much your entire bone marrow just does not work anymore, and you get low cell counts in everything. So you have anemia, so low red cells, leukopenia, low white cells, thrombocytopenia, low platelets, and then all your symptoms. So I didn't put the symptoms up because just think about what these cells all do, and then you can come to the conclusion of what the symptoms are. So if you have anemia, your red blood cells are low, so you have hypoxia symptoms because red blood cells carry around oxygen. Leukopenia, you have increased infections because they fight infections. White cells fight infections. And thrombocytopenia, platelets help to clot, so you'll get increased bleeding. Yeah? And pretty much for all the leukemias, when I talk about it later, just think about what cells are being affected, and it will help you a lot to understand what symptoms should be present. And on your blood film, it's pancytopenia, so decreased amounts of cells in everything, and then decreased reticulocytes because you're getting less production in general. So now we'll talk about megaloblastic anemia. So the definition of megaloblastic is a macrocytic red blood cell. So you can see how this is a lot larger than this, which is a normal red blood cell. And you have hypersegmented neutrophils. So normally there's like about 3 to 5 lobes, and in this you have like 1, 2, 3, 4, 5, 6, 7, 8. So yeah, so just remember that's the definition. So can you guys remember which two conditions are the megaloblastic anemias? Yeah, that's good. Again, another slide that I shamelessly ripped from Louisa last year. This helped me so much to understand B12 and folate, so I thought I'd include it here for you guys. So, I'll go through this quickly. So your B12 is absorbed in the terminal ileum, and this is different from folate, which is absorbed in the jejunum. So you just have to remember this. So you guys should recall from gastro that B12 is absorbed through the help of intrinsic factor, which is produced by the parietal cells in your gastric mucosa. So with pernicious anemia, because you're lacking intrinsic factor, you get B12 deficiency, or you can get B12 deficiency. So you find B12 in a lot of animal products like milk, meat, eggs. And usually B12 deficiency doesn't present for a long time because you have a lot of storage in your liver, so about 3 to 5 years. This is very different from folate because folate only doesn't have a lot of storage, so it can present very suddenly. And also, you get your folate from leafy green vegetables. So with the causes, again, going back to the iron deficiency, so because iron was absorbed in the duodenum, if you thought about causes which affected the duodenum, including like surgery or inflammatory bowel conditions, they could help you to think of causes. So the same principle applies here. In the terminal ileum and the jejunum, if that's cut out, you're going to have poor absorption. If there's an inflammatory bowel condition like Crohn's or celiacs, you'll have poor absorption as well. And then certain drugs can also cause folate deficiency, like methotrexate. The mechanism is a bit unclear, but it can and has been proven. So as I said before, the onset is very different for both conditions. So B12 is gradual over many years, and folate is very rapid. So do you guys remember what happens if you have a folate deficiency in a pregnant woman? Sorry, what was that? Yeah, that's good. You guys are like so much more on top of things than we were last year. So the symptoms, so the most important symptom of B12 is peripheral neuropathy. So do you guys all know what peripheral neuropathy is? No? It's not like dermatomal distribution loss. It's just like loss from, so let's say I had peripheral neuropathy on my hand. My sensation would just start decreasing like from distal to proximal. There's no dermatomal distribution that's lost. Okay? So it just starts losing. It's like diabetes. Like, you know how, is it glove and stocking distribution? It's sort of like that. That's what peripheral neuropathy is. And with folate, you don't get any neuro symptoms. So the investigations, you can sort of read this in your own time, but just pretty much just think blood tests. And the way you treat it, you just have to remember hydroxycobalamin is for B12 and folic acid is for folate. Yeah? So a really, really key point here to understand and also remember is that if somebody presents with folate deficiency, no matter what, you still need to rule out B12 deficiency, because if they have a simultaneous B12 deficiency going on and you just treat them with folic acid, then they're not going to be anemic, but they're still deficient in B12, so they're going to get peripheral neuropathy, and then it's irreversible, and then you're just impairing your patient's function and mobility for the rest of their life. So you need to rule out B12 deficiency, even in someone who comes in with folate deficiency. Yeah? Cool. I think I've got a couple questions now, so just feel free to yell out. My voice is dying as well. Are you sure? Always think for treatments, a good rule of thumb is always think lifestyle first, because Monash loves that, and then you think the least invasive stuff. Oh, it should also say, how would you initially treat her for her anemia? All right, I'll just go through it. So the answer is oral iron, because you don't want to give her a blood transfusion straight away, because that's, A, it's just like very invasive, and B, you can fix the problem with oral iron and then she's good to go. So yeah, just do oral iron. So elderly man with anemia secondary to chronic renal failure, he's initially given oral iron, but his symptoms do not improve. Which of the following would you consider next? Did someone say D? Yeah, it's correct. So I don't know why they're giving him iron, because it's a normocytic anemia most likely, because he has a renal failure, so he's low EPO. So you just want to treat the cause. So if he has low EPO, just give him EPO. Yeah. A woman presents to GP with weight gain, constipation and fatigue. So, think endo, giving it a bit of a clue. Her FBE shows macrocytic anemia. Which of the following is the most likely diagnosis? Yeah, someone said hypothyroid, yeah. So I think I kind of gave it away, but just always think about hypothyroidism for macrocytic anemias because it can always present like very non-specifically and look like an anemia. Well, it is an anemia, but yeah, it can like kind of trick you. You might think it's B12 or folate if you see macrocytic, but just keep hypothyroidism in the back of your mind. So a woman has pernicious anemia. Which of the following would treat her anemia but not her neurological complications? Yeah, someone said D. So I just went through this in depth before, so I'll go through it again. Like, never, ever, ever, like, fail to exclude B12 before you treat someone for folate because someone will, like, get really bad peripheral neuropathy, and that's not good. So with transfusion medicine, just remember this table pretty much, and you're, like, good to go. Do you want me to run through it, or are you guys comfortable with like all the antibodies in the serums and all the antigens and stuff? All right, I'll just go through it quickly. So if you have blood type A, you have A antigens. If you have blood type B, you have B antigens. AB, you have A and B. And O, you have no antigens. That's pretty straightforward. And then you just think of the opposite. So in blood type A, you can't give them blood type B, so they have anti-B. In blood type B, you can't give them A, so they have anti-A. In blood type AB, you can give them anything, so they have no antibodies. And in blood type O, you can't give them any blood apart from O, so they have anti-A and anti-B. Yeah? Cool. So a woman is blood type A positive. Which of the following is true? Yeah, it's D. So she cannot donate blood to people with O because O can't receive anything apart from O. She's not at risk of developing anti-rhesus. That only happens in rhesus negative people, women. She cannot receive type AB because AB has A and B antigens, and her serum contains only anti-B antibodies. Yeah? So ABO genes with AB, and O blood types. The most common rhesus factor is D. That's the only one you need to know. You don't even need to know it's called D. You just need to know positive and negative means a rhesus positive or rhesus negative. And do you guys know the difference between all the immunoglobulins like IgG and IgM and stuff, and like which ones can cross the placenta and stuff like that? All right, so hemolytic disease of the newborn. So by far the most common way it happens is you have a rhesus negative mother. Okay, rhesus negative. So anything in red and underlined is like important. Rhesus negative mother. She has a rhesus positive child. During childbirth, there's mixture of fetal and maternal blood. So she becomes sensitized to rhesus positive. So she develops antibodies for rhesus positive. Therefore, in future pregnancies, if her baby is also rhesus positive, because she has developed those antibodies against rhesus positive, therefore, the antibodies will cross the placenta and they will start latching onto the baby's baby's red cells and cause hemolysis. So that's why you get hemolytic disease of the newborn. That's the most common way. This is like not important to know, but just know that it can happen in other ways. Cool? All right, this is sort of less important for now and more important for later. So next year, you'll come across these terms. Group and hold just means like find out the patient's blood and hold a bag of blood for them and cross-match means get them blood immediately because you want to use it. So with your indirect Coombs test, you guys seemed pretty comfortable with that, so I won't go through it. You guys can just read it in your own time because, yeah, it's getting a bit late. But with acute hemolysis, that's due to a big difference in the blood types, so ABO, and then you can also get delayed hemolysis, so you get smaller, less important antigens on the surface of blood, which are incompatible, and you get delayed reaction. So do you guys know what the symptoms of hemolytic anemia are? Yeah, primarily jaundice, and also anemia in general. So all your anemia symptoms and jaundice as well. So now we'll go through all the hematological malignancies. So again, we've got this picture. So you pretty much have to just remember which cells come off which branch for you to understand hematological malignancies like well. So you need to know which ones come from the myeloid side and which ones come from the lymphoid side. Yeah? Cool. And this is also a good picture that was on last year's revision lecture. It sort of separates them, all the conditions into the individual lineage and then which cells are responsible as well. So that was pretty good. So you guys can have a look at that in your own time. So a question. A man is diagnosed with polycythemia rubra vera. What is the most likely sign to be found upon examination of his eyes? Yeah. Do you guys know what injected sclera is? It's pretty much just a red eye. And the reason why you get a red eye is because do you guys know what polycythemia rubra vera is? Okay, well, I'll go through it now. Hey, Calvin, does this thing work? Hello? Okay, cool. Oh, this is so much better. Polycythemia rubra vera is one of your myeloproliferative neoplasms. So what that means is you have cells from the myeloid lineage. So we can go back and have a look at that. So cells from the myeloid lineage, all these cells here, yeah, and these are proliferating in excess and abnormally. So that's why it's called myeloproliferative neoplasms. Yeah, it's all in the name. So you have 4 types which are considered myeloproliferative neoplasms. You have chronic myeloid leukemia, polycythemia rubra vera, essential thrombocytosis, and primary myelofibrosis. And it's important to know the difference between all of these. And just know that any of the 4 can progress to significantly worse conditions with bad prognosis, such as AML. Yeah. So just beginning with polycythemia rubra vera. This JAK2 gene is found in a lot of these myeloproliferative neoplasms. So 95% of people with polycythemia rubra vera have a JAK2 mutation. So as we were talking before, it's part of the myeloproliferative neoplasms. So the red blood cells are part of the myeloid lineage, correct? So with polycythemia rubra vera, you have increased proliferation of red blood cells, and that's it. So some of the symptoms you get with increased red blood cells is you have itchiness after a hot shower. This is like a buzzword. Injected sclera, so red eyes, because you have so much excess blood that it begins pooling in areas of your body, and the eyes is a common area that it pools, like just deposits in a sense. And then because the blood is so thick and so viscous, you can get headaches and burning and tingling and paresthesia of limbs. Yeah? Does that make a bit more sense to you guys? So polycythemia just means increased red blood cells. And that's all. So with essential thrombocytosis, it just means that you have increased amounts of platelets. So thrombo is platelets. Yeah, and 50% have a JAK2 mutation. You don't really need to know the treatment as such, but basically this is like, it just reduces your bone marrow's function, so your bone marrow doesn't produce as much of the abnormal platelets. So in a way that helps. Yeah? Does that all make sense? Did anyone have a question? Yeah.
Sorry, why do you get more bleeding in essential thrombocytosis?
Look, I'm not really sure, but it's just a buzzword, I suppose. But definitely have a look, because I don't really understand the mechanism, but I think it does happen.
Yeah. So
Yeah.
when you've got lots of platelets, you also clot a lot more. That uses up all your clotting factors, so then when you actually get an injury, you've got no clotting factors for it, so you bleed more.
Oh, okay, cool. Yeah. Maybe you want to give the talk, because you know more than I do. But thank you. So a patient presents with a headache and numbness in the arm and leg. The FBE showed increased hemoglobin and increased hematocrit. Yeah. And which of the following is least likely? Which one? Yep. Yeah, it's not too hard. So do you want me to go through it? So polycythemia rubra vera, you're going to get similar symptoms. If you go through altitude training, hang on, I'll just go to the next slide. It'll be easier. So this is a bit of a tangent, but it did sort of come up in past years, like this topic, a question or two. So you can get secondary polycythemia to a lot of conditions, but generally it's due to an increased requirement for red blood cells, so things like altitude training or just states of chronic hypoxia. So you can get it in COPD. Like, it's not that common, but it can happen, and it was assessed last year. So COPD, sleep apnea because you're not breathing in enough oxygen at night, and altitude training. And then if you give yourself more EPO through doping, or if you have a tumour that's secreting EPO, you get the same effects. So you get increased red blood cells, and it's not cancerous. It's like a normal physiological process. Okay? But you can get similar symptoms to polycythemia rubra vera. Cool? So now we'll talk about primary myelofibrosis. So again, the JAK2 gene is prevalent in 50% of people. So it's a bit confusing because it's a myeloproliferative condition, but what happens is you get a lot of increased abnormal proliferation of hematopoietic cells, and they release a lot of cytokines in this condition, and this causes aggregation of a lot of other enzymes, which eventually results in fibrosis of your bone marrow. So the initial phase is myeloproliferative, and then afterwards you get fibrosis of the bone marrow, and you get pancytopenia. So all the symptoms are pretty similar to aplastic anemia. Just think about what all the cells do, yeah? And then an important thing to note is there are 3 conditions which give you massive splenomegaly. So if you see those 2 words, massive splenomegaly, think about myelofibrosis. So it's a 3 M's. So myelofibrosis, malaria, and CML. So myelofibrosis, malaria, and CML can all give you massive splenomegaly, and those are the only 3 conditions. So all these symptoms are due to lack of blood cells because you're pancytopenic. And on your blood film, you can get teardrop cells, so these cells again. So you can get them in thalassemia as well, correct? So the way it was taught to me, and the way I remember it, is you just think that the bone marrow is crying because it's been fibrosed or taken over. Yeah, it's pretty cheesy, but it helps you remember it. And again, hydroxyurea is the cytoreductive agent. So it tries to slow down the amount of proliferation. So in that way, it helps stop excessive fibrosis or helps to slow down the fibrosis. And then if it's really bad, and if you meet certain criteria, you can get a bone marrow transplant. And CML, probably the one you need to know the most about. It's about age about 50. Definitely remember this, Philadelphia chromosome 922, like imprinted onto your skulls. Like this is important. Every year there's a question. BCR, ABL. This picture sort of helps you to understand what is happening with the translocation. So with the BCR on chromosome 22, that doesn't move. Your ABL and anything after that is translocated onto the BCR. So this bit goes to the chromosome 22 and this bit switches over, and then you get this abnormal gene which causes CML. So this is probably like the most exam relevant and important thing to take away from hematological malignancies. So there are 3 stages to CML. So you have a chronic stage where there's like nothing really going on, but you have the translocation. So it's been diagnosed, but you don't have too many symptoms because it's not too bad. Do you guys know what blasts are, by the way? Yeah, so there aren't too many blasts. So most of the cells present still have a functioning purpose. That's the way I like to think about it. And then when you're into the accelerated phase, you have more blasts, so you have more symptoms because more of your cells are non-functioning, non-differentiated hematopoietic cells. Yep. And then when you're in the final stage, called blast crisis, you have more than 20% blasts in your bone marrow, and it essentially behaves like AML at this stage, and it's quite severe, and the prognosis is not as good once you reach this stage. So just know 922, BCR, ABL, 3 stages. The symptoms are very similar to other leukemias, but just make sure, because it's myeloid leukemia, it only affects the cells from the myeloid lineage. Yeah, it's in the name. So again, with all the myeloproliferative neoplasms from before, they only affect the myeloid lineage. So your B and T lymphocytes, because they're from the lymphocytic lineage, they're not affected. But since your myeloid lineage produces so many cells anyway, it's quite severe. Yeah? And this one you do need to know the treatment of. You need to give them imatinib. I'm sure you've come across this, because BCR, ABL sort of enhances tyrosine kinase expression. So if you inhibit it, you can potentially slow down the cancer or even get it to go into remission. Cool? So with AML, so this is the condition that all the myeloproliferative neoplasms can progress to. So it can occur in all age groups because all of the myeloproliferative conditions can just progress to this if not controlled well enough, as I've said here. It's a lot more severe. So the way I like to think about it is, so ALL, which is in the next slide, is in children, so L for little kids, and M is like major. So that's the way you differentiate AML and ALL, or that's how I like to think about it. And again, with the symptoms, you just think about the myeloid lineage and which cells are being affected. So anemia, your red cells are being affected. Increased infections, your white cells are being affected. Increased bleeding and bruising, all your thrombocytes are being affected. And then these symptoms can also present in select cases. And the big buzzword, I don't think you'll ever get a blood film like this. So don't worry too much. But if you see like a stem which says so-and-so has come in with fatigue and they're noticing that they're getting sick more often and stuff like that, and they did a like a blood film and it showed our rods, just go AML, because our rods only occurs in AML pretty much. So it's these like lines. Do you see like these lines which are like inside the white blood cell cytoplasm, just like all over the place, crisscrossing. Yeah, those are called Auer rods. So yeah, but I don't think you ever need to recognize it. You just need to know that it is a part of AML. Cool. And then with the lymphocytic leukemias, ALL, different from AML because L is for little kids. And then CLL is probably the most common leukemia that's present in the adult population. And the buzzword is rubbery lymph nodes. And people, it's not too severe, and people don't die from it. They often die with it. So, yeah, it's not the worst cancer to get out of all of these. And the blood film, like buzzword, is smear and smudge cells, because these cells are so fragile that when they're doing the blood film and they're physically smearing the cells onto the film, they become like broken up. Cool. So now I'll talk about lymphoma. Sorry, there's like been all this just me talking, and there's questions at the end in a couple slides, I think, for this section. So lymphoma is pretty much tumors in lymphoid tissue, and you have two different types, two distinct types. You have Hodgkin's lymphoma, which is about 15% prevalence. This is the one you want to have out of the two because it has a significantly better prognosis. I think, if you might recall, a long time ago, I think Delta Goodrum might have had Hodgkin's lymphoma, and she's pretty good now. I mean, health-wise, she's like back to normal. And the presentation is painless, rubbery lymph nodes, which become tender after alcohol. So this is like in your stem, if you see someone, they've drunk alcohol, they've had lymph nodes which were not tender, but now they're tender. Okay, think Hodgkin's. But they'll usually give you not a blood film. They tell you Reed Sternberg cells were seen on blood film. So this is just like B lymphocytes, which look like mutated because they are mutated. And the symptoms you get, again, think back to what your B and T lymphocytes do. But primarily, all the lymphoid leukemias and lymphomas are B lymphocytes, primarily. Rarely they'll be T. But if you think about what they do, then it'll help you to come to the symptoms. But pretty much, if in doubt, just say, they present when they're tired, they have fevers, weight loss, night sweats, lymphadenopathy, and that covers all your leukemias and stuff. That's symptoms that are pretty common amongst the hematological malignancies. So do you want me to go through that again? Fevers, weight loss, night sweats, lymphadenopathy. Those are probably pretty common. And then with non-Hodgkin's, the prognosis is a lot worse. And especially if you have high-grade non-Hodgkin's, such as Burkitt's and diffuse large B-cell lymphoma. These are quite bad, so you want to treat them and control it as quickly as possible. You just need to remember these buzzwords. So with Burkitt's, think c-Myc oncogene. There isn't really a way I can help you to remember that. You just have to remember it. And follicular lymphoma is BCL2 translocation. This is not the same as before the BCR ABL of CML. This is different because it can get a bit confusing. Well, I was confused last year. But follicular lymphomas are a lot better because, they're still not good, but they're a lot better than the high-grade ones because they progress a lot slower. And with multiple myeloma, I got really confused last year because myeloma makes it sound like it's from the myeloid lineage, but it's not from the myeloid lineage. It's the plasma cells, which are from B lymphocytes, correct? So you have a cancer of the plasma cells, and you have abnormal and rapid proliferation of a lot of antibodies, which don't do a whole lot, but they can deposit in a lot of areas in the body. So the symptoms that you get with multiple myeloma are this acronym, so CRAB, hypercalcemia, renal failure, anemia, and bony lesions. So the way I like to think about it is you have all these antibodies that are, and like these cancerous plasma cells, which are just like proliferating all these antibodies. And these tumors of plasma cells can deposit in bones. So when they deposit in bones, they displace the normal architecture that is there. So that's why you get your bony lesions. Then, because you're displacing all that normal architecture there, all the calcium stored in the bones gets released into the bloodstream. So you get hypercalcemia, following. And then the antibodies which are produced so rapidly and which have no function, they can deposit all over the body. And a place they like to deposit is in the kidneys. So that's why you get renal failure. And then from your renal failure, you're not producing EPO, so you get anemia. Yeah? Does that like sequence make sense? Yeah? Cool. So just remember, even though it's myeloma, it's from the lymphocytic lineage. So the investigations. So because you have decreased EPO, because you have renal failure, you have normocytic normochromic anemia, your ESI is high, like over 100. So there are a couple conditions which your ESR can get over 100, and multiple myeloma is one of them. So this is quite a good indicator, but probably the buzzwordy stuff is on your blood film, you see these rouleau bodies, which look like a whole heap of like coins, I suppose, stacking on top of one another. So that's what rouleau bodies are, just these things here, and then these things, and that, and that. Do you guys see how like they're all clumping together, but it's not like random agglutination, it's just like linear. So that's rouleau bodies. And you can see Bence-Jones proteins. This isn't dipstick, this is like urine protein electrophoresis. So like looking through a microscope and stuff. And then on X-ray, you can get pepper pot skull. So that's just the bony lesions migrating to your skull. Yep. And then the treatment is stem cell therapy and chemo. Those are like the two main options you have. So now I think we have a couple questions, hopefully. Cool. Which of the following statements is false? So just like shout it out if one of you know, because I think we need to get through this quickly. Which one? D? Yeah. So I told you before, lymphoid leukemias are most commonly B cell, and the rest are all true. So in regards to CML, which of the following is true? Yeah, so the BCR-ABL gene. Yeah, cool. Oh, only two questions. So with blood films, I don't have too much blood films, but I thought I just put the more important ones or the ones that were a bit tricky to sort of differentiate. So with your target cells, I went through this before, so look, it just looks like a target sign. And that can happen in, if you remember this acronym, so HALT, so HB deficiency is iron deficiency, essentially. As in like, for the purposes of the acronym, just like, yeah. Asplenicism, liver disease, and thalassemia, these can all present with target cells. Pencil cells, this can present primarily in iron deficiency. However, there is also this condition called hereditary ellipsis. So yeah, you don't really need to know this, but just know that this isn't just exclusive to iron deficiency, but for your level, if you see this on your exam, it's going to be iron deficiency. Cool? And then you have these things called spur cells and Burr cells. So, yeah. So with spur cells, there's like this spike which occurs randomly throughout the red blood cell. You don't really need to know this, but it's like, in case you see it later on, you can tell the difference. So you have that spike, so all these spikes surrounding the red blood cell, and these have like serrated edges. And what I mean, so it's different. There's no like spike coming out. And what I mean by artifact is it can just happen randomly when someone is doing a blood film and it's not due to any condition. So yeah, just keep that in mind, I suppose. And then rouleau bodies we went through before, so it's just like the coin stacking. So you guys can see there's all these red blood cells just stacking on top of one another. Cool. So now we'll go through clotting and hemostasis, the last bit. Almost done. So with the normal physiology, this is a bit complex, but hopefully I can simplify it as much as possible. Normally in your body, things are clotting and things are being anticoagulated, just generally in your body, because your platelets are responsible for just plugging those micro tears in your vasculature and things like that. So just know that normally both processes are occurring. It's just a sort of balancing scales, which one's more dominant than the other. And you have some natural anticoagulants in your body. So the endothelium of your blood vessels. So the smoothness of the endothelium prevents contact with the subendothelium and the blood. So the subendothelium contains a lot of factors, and the collagen there is procoagulant. So the endothelium acts as a barrier. These two things, I put them in there because it's good to have some idea of what they are, but you don't really need to know what they do. So pretty much just know that these are additional layers on top of the endothelium which prevent coagulation normally. Okay? So glycocalyx, who knows, and thrombomodulin. All right? So don't remember what they do, just know that they're layers on top of the endothelium which help to also prevent clotting. And then the subendothelium, as I talked about before, has a lot of procoagulant stuff going on there. Cool? So I'll just go through the clotting cascade as detailed and as sort of succinctly as possible. So when you have damaged vessels, the normal reaction is vasoconstriction of the damaged vessel to prevent the blood from pooling and forming hematomas and leaking out and causing all sorts of other problems. So the normal reaction is, first you have a vasoconstriction. Then because your endothelium is damaged, the subendothelial collagen is exposed. Yep. So the subendothelial collagen is exposed, and the platelets are attracted to the collagen, and they form a plug, and they are helped by von Willebrand's factor, which is also a carrier for factor 8. I'm sure you guys know. And then von Willebrand's factor helps to further promote clotting through a lot of different mechanisms, which is not important at a second year level. But just know subendothelial collagen, platelets go there, von Willebrand's helps, and then you get intrinsic and extrinsic pathway. So these three steps happen before you even get to intrinsic, extrinsic pathway normally. But as I'll talk about, your extrinsic pathway is very, very, very quick because there's not a lot of steps involved. So it can happen almost in unison. So the thing that activates the extrinsic pathway is trauma to blood vessels. So trauma to blood vessels activates the extrinsic pathway, and you have tissue factor, which is also factor 3, and factor 7. Oh, I have a picture in the next slide, which I'll go through, and it will make a lot more sense. And then the intrinsic pathway is a lot slower because there's a lot more steps involved, and it's activated through the previous 3 sort of steps, and then the subendothelial collagen from being exposed also activates factor 12.
And just know that you need calcium for both pathways. Cool. So this diagram, if you need to remember one thing for clotting for your exam, if you can draw this all out, don't worry about like these red and green lines and stuff. But if you can draw all the black lines out, then you'll like have pretty much like all the knowledge you need at a second year level to tackle all your clotting and hemostasis questions. So I'll just run through it quickly. I won't really, hang on. So in your extrinsic pathway, you can see how it's much shorter, yeah? So trauma activates tissue factor, and also, so when it has an A at the end, it just means this is the inactivated form and that's the activated form, okay? So with trauma activates factor 7, and then trauma also activates tissue factor, and these together, bam, straight away, they activate factor 10, and then you get your thrombin and fibrin clot forming. Whereas with your intrinsic pathway, you have factor 12 activated by the subendothelial collagen, and then it just goes factor 11, factor 9, factor 10. So factor 9 and factor 8 work together. So factor 8 adheres to von Willebrand's factor. So it's sort of an accessory like pathway, like it helps it along. So 12, 11, 9, 9 plus 8 is like, it works together on 10, and then you get all this. So there's really no easy way to remember it. The way, everyone has a different way of remembering it. I remember last year, the lecturer showed us her way, and I was like, I have no idea what's going on here. But just like, you pretty much need to sit down and just try and draw it out, and it'll help you a lot, or it helped me. So this is really key and really important to both understand and remember. So yeah, I got a question. So a man cuts himself when using a chisel and started to bleed. Which of the following initiates the clotting cascade? Yeah. So trauma equals tissue factor equals extrinsic pathway. So there are some coagulation studies you can do to see if someone's ability to clot is being impaired or not. So the two main tests that you can order are PT or APTT, and the way that helps me the most to remember what they do, so it has one T, so T for tennis, so you play tennis outside, so it's part of the extrinsic pathway, and there's two T's here, so table tennis, and you play table tennis inside, so it's intrinsic pathway. Cool? And also, something to remember is whenever you see INR, it just means prothrombin time, but in a ratio of what is normal. So the person's prothrombin time over the normal value equals their INR. Cool? And with your mixing studies, I'm sure you guys had like a tune on it and was like thoroughly confused. So what helps me to understand is, so with your mixing study, first of all, you have 50% of the patient's blood serum and 50% of normal serum. So normal serum contains all the factors and all the other stuff in there which helps clotting. So if you add those two together and you get a normal APTT, that means that the original person's blood serum has a factor deficiency. Yeah. And if the APTT is still prolonged, even though you added the normal serum in which contains all the factors, it means that an inhibitor is present. So most likely some drugs can inhibit certain factors, or other conditions can also. Cool? So does that all make sense so far? We're almost at the end. All right, so I'll try and explain this briefly. So you get prolonged. Do you guys still remember the picture I showed you before? Like which factors do what? Or just bring it up. Just bring it up now, and then this will make a bit more sense. So in liver disease, it affects both because your liver produces a lot of the clotting factors. So naturally, if you're deficient in clotting factors, you have prolonged bleeding. Hemophilia is factor 8 deficiency or factor 9 deficiency. So 9 and 8 are both part of the intrinsic pathway. So you get prolonged APTT. Von Willebrand's is a carrier protein for factor 8. So you get prolonged APTT. Heparin as a drug, you don't need to know the mechanism, but it increases the effect of something which has an effect on preventing clotting in the intrinsic pathway. So that's why ignore this for now. This is not important at your level. Factor 7 deficiency. So if you recall, tissue factor and factor 7 are primarily responsible for your extrinsic pathway. So if you're deficient in factor 7, you have a prolonged extrinsic pathway bleeding time. So you have prolonged PT. Warfarin is essentially it's a vitamin K inhibitor. So the factors which are responsible, which rely on vitamin K to work, are 2, 7, 9, and 10. So because factor 7 is affected, because it's part of the extrinsic pathway, it will affect the extrinsic pathway's bleeding time more. So factor 10 and factor 2 are part of the common pathway. So you also get some APTT prolongation, but it's by far more prolonged in the extrinsic pathway. And I'll talk about this later when I talk about all the drugs. But hopefully you guys can look back on this and then sort of figure out by yourselves as well when you're doing revision why and what mechanisms are responsible. Cool. So with your bleeding disorders, hemophilia is probably the most important one for you guys to know. So hemophilia A is factor 8 deficiency. Hemophilia B is factor 9. The buzzword is hemarthrosis or bleeding into joints. And you also get increased bleeding or easier bleeding and bruising because you're deficient in a factor. Cool. And then von Willebrand's disease, you have decreased von Willebrand's factor, so you have decreased ability to bind factor 8 to your initial clot. So you also get easier bruising and bleeding and mucocutaneous bleeds. So these are like bleeding of like nose and gum surfaces and things like that. So this is like a buzzwordy sort of thing for von Willebrand's disease. And you can get increased bleeding if you're deficient in factors from liver disease or you're deficient in vitamin K, which is responsible for some factors in your clotting cascade. Cool? So this is sort of, in your own time, have a look at this. But if you look back into the pathway, protein CNS, hang on, this is quite important, I'll explain it. So protein CNS, what their normal function is to regulate the size of your clot. So it does this by inhibiting factor 5 and factor 8. So in that way, it's a natural anticoagulant, correct? Yeah. So I'll say that again. Protein C and S normally inhibit factor 5 and factor 8. So they inhibit, therefore they are anticoagulating because they want to control the size of the clot that is formed. Cool? So if you have a deficiency in protein CNS, the normal anticoagulant function that they give is disrupted, so you become procoagulant. Yeah? Does it make sense? If you guys aren't sure, I can try and go a bit slower and explain it. Yeah? If you're all good, we'll move on. Yeah? Good? Cool. So I'll talk a bit about the arterial and venous clots. So Virchow's triad is what is responsible for almost one of the aspects of Virchow's triad is almost always responsible for an episode of venous thromboembolisms. So you have endothelial injury, which causes the exposure of subendothelium, which, if you recall, is procoagulant. If you are in a hypercoagulable state, or if you have stasis of blood, like blood pooling, that can help to form clots simply by the physics of the blood like being there for a prolonged period of time. And turbulent blood can, I also put turbulent blood in there because if you have turbulent blood, it can damage the endothelium and then cause the subendothelium to be exposed. So you can have a look at this table in your own time because it's like not that important for second year, but important later on. Yeah, cool. So now we're moving on to drugs. So I think we only have about 5 or 6 more slides of content, and then I've got a couple questions at the end, which should be good. So with unfractionated heparin, you don't really need to know the mechanism of why it works. Just know that it affects the intrinsic pathway, and you need APTT to monitor it. And you can reverse unfractionated heparin through protamine sulfate. But an important thing to note is in the hospitals nowadays, almost always when you need heparin, you give them low molecular weight heparin because it has a better risk profile, and so therefore it's safer, and it's I think it's cheaper as well, which is what hospitals care about a lot as well. So it's much more selective for factor 10. So as you can see here, don't look at this, but essentially you're chopping the heparin like at a predetermined sequence, and then the binding site of the low molecular weight heparin, like the binding shape, changes to be more like specific towards factor 10 only. One of the drawbacks of low molecular weight heparin is that it's irreversible, so it's hard to... By irreversible, I mean it's difficult to reverse. Like you can always reverse something if you just give the patient a lot of clotting factors, but it's expensive and it's like invasive, which is not good. So it's also the most common way to bridge someone to warfarin. Have you guys heard the term of bridging to warfarin before? So I will explain this in the next slide, so just keep this in mind. So also have a look at this table in your own time, because I've already sort of talked about it, but this sort of summarizes it neatly. So with warfarin, it affects the extrinsic pathway more than the intrinsic pathway. So that's a bit in depth, but just think warfarin is extrinsic pathway. So the reason why is it's a vitamin K inhibitor, and the way that was taught to me, which stuck with me, was you just think about the TV channels, so channel 2, channel 7, channel 9, and channel 10, and then that helps you to remember the factors which are vitamin K dependent. Yep. So if you're inhibiting vitamin K, those factors which are vitamin K dependent are also inhibited. True? So because you're inhibiting factor 7, this is the most important factor out of all of them probably. So it impairs the extrinsic pathway because the extrinsic pathway was so short. So if you affect this, it has a greater effect on anticoagulation of that pathway. So your extrinsic pathway will be affected more than your intrinsic pathway. So a key point to note is protein C and S are also vitamin K dependent. So in the first couple of days, by inhibiting vitamin K, you also knock these two out. So their original anticoagulant effect is now gone. So you're in a state of relative procoagulation, and that's bad because if you're giving someone warfarin, they've probably already had a clot for whatever reason, or they're more likely to clot. So that is why you want to give them low molecular weight heparin in the first couple days because it acts very quickly and it is able to cause anticoagulation for those first couple days, and it's very safe before the warfarin begins to have an overall anticoagulant effect. Does that make sense? It's a bit tricky to get your head around, but I'll repeat myself. So these two, does someone have a question? So protein C and S are natural anticoagulants, and by getting rid of them, you become procoagulant for the first 2 to 3 days before the overall effect of warfarin becomes more anticoagulant. Cool? So some important points to note is never give warfarin to someone who's trying to be pregnant or to a pregnant lady. Also, you want to eat the same amount of dietary vitamin K because you need to monitor warfarin very closely. If you affect the amount of vitamin K intake that you normally get, then you're going to affect the dose of warfarin that you need. And also, you don't want to drink alcohol or reduce the alcohol intake because alcohol can reduce vitamin K absorption from memory. So if you do that, you're more susceptible to bleeding, and bleeding is as great a risk as clotting if you have someone on anticoagulants. Okay? So INR monitoring, so that's extrinsic pathway. INR is the same thing as prothrombin time. So yeah, just look at these values in your own time. NOACs, it's good to have like a general idea about this. It's not tested much at all, if rarely. Just know that this stands for new oral anticoagulants. So it's oral, once or twice daily. So patients really like it because they don't need to be injected with low molecular weight heparin, and they don't need to like go for blood tests all the time to check up on their warfarin levels and things like that, which is really annoying for patients. So they don't need monitoring either for NOACs, but it's difficult to reverse. So if you screw up, then you're going to be in a lot of trouble. So that's why it's still not like super preferred treatment yet. Yeah, so the way I remember which ones do which, because these are the only three that you're ever going to get. So rivaroxaban and apixaban, they all have the last three letters are ban, and the letter preceding the last A is like one consonant. It's pretty stupid, but there's one consonant, so like one, and there's two here, so like two. Like, it's so stupid, but yeah, that's just how like it helps me to remember. But if you can't remember it, it's like it's not too important to know. So we'll go through some antiplatelet. We're almost done, guys. So antiplatelets, you have aspirin and clopidogrel. You don't need to know the mechanism of clopidogrel at all. Just know that it's an antiplatelet. But aspirin is probably the more common and more preferred antiplatelet. So at low doses, it's enough to suppress. You know how aspirin is a NSAID and it's a non-selective COX inhibitor? So COX-1 and COX-2. COX-2 is more the inflammatory effects. So at higher doses, it would act more as an NSAID, and at lower doses, it does enough to inhibit COX-1, which is sort of your homeostasis like stuff, and then all your clotting and things like that. So if you give them low-dose aspirin, it's enough to have that antiplatelet effect without affecting COX-2. And don't give aspirin to people with peptic ulcers because NSAIDs, yeah. You guys know how NSAIDs can cause peptic ulcers, right? Non-steroidals cause peptic ulcers, true? Yeah? Okay. And then you have your thrombolytics, so these are like what you can give. Yeah.
Wait, sorry, back to the aspirin.
Yeah.
Why did the COX inhibiting
Because, did you want to know why the COX inhibiting had an antiplatelet effect? So, at low dose. You know how there's COX-1 and COX-2? So COX-2 is like your inflammatory pathways, so all the cytokines and things that mediate inflammation in your body. And COX-1 is all the homeostasis, things like the platelet production and things like that. So if you inhibit COX-1, then you're inhibiting the body's normal like homeostasis mechanisms. So that's why you get, don't take my word for it, but it basically affects COX-1, which is responsible for platelets. Does that help you? Cool. And with thrombolytics, so these are agents you can give in acute situations when the patient has like a huge clot and you want to get rid of it because they're pretty much going to die if you don't. So you can give streptokinase. So this is like the pathway. So I'll briefly explain it. So when you have a clot in your body, so whether or not it's pathological or normal, you have plasminogen, which like sort of floats around, and then this thing, tissue plasminogen activator, activates plasminogen to plasmin, and plasmin is responsible for breaking up the fibrin clot that is formed. So if you can activate this pathway, you can remove the fibrin clots. Yeah? So streptokinase is produced by certain bacterium, and it activates plasminogen, so therefore you get plasmin and fibrin degradation. You can only use it once because since it's from a bacterium, you can develop antibodies to it, and if you give streptokinase to a patient again, they will have an allergic reaction, which is bad. And then the next drug is alteplase. So alteplase is basically just a recombinant TPA, yeah, tissue plasminogen activator. So it activates this pathway again and it causes fibrin degradation. And you want to use it in, you don't want to, but you can use it in AMI, ischemic strokes, so strokes which are caused by clots, and like a huge, do you know what pulmonary embolisms are? Yeah, so if you have a really, really bad pulmonary embolism, you can also give alteplase. So now I've just got like 5 or 6 questions which are pretty good. So which of the following would cause a prolonged APTT? Yeah, that's pretty easy. I won't. Do you want me to go through the why the rest? No, that was easy. Which of the following would not increase INR? No. Just know that DIC can increase intrinsic and extrinsic pathway bleeding. It's pretty complex, but yeah. No. So if you have decreased amounts of fibrin in your pathway, do you remember how fibrin was the end result of the clotting cascade? So if you have decreased amounts of that, then decreased amounts of precursor stuff, which is fibrinogen, then it will take you longer to bleed a clot, so you would have an increased INR. Yeah? The answer, I'll just go through the answer. The answer is unfractionated heparin because it affects the intrinsic pathway as we talked about before. Yeah? Just refer back to the slides before. Warfarin inhibits which of the following? Shouldn't be too hard. B, yep. Then the other factors it inhibits are 2, 9, and 10. Yeah? A 30-year-old lady who is 6 months pregnant has a deep vein thrombosis. Which of the following would be the preferred treatment? Which one? This might be a bit complex for you guys, but I just want to, so the answer is B. So the reason why, I just wanted to reiterate that you never want to give warfarin to a pregnant lady, ever. And Also, you don't want to give warfarin as initial therapy ever either, because it's a shocking idea, and you'll make them clot more and they'll die. So, yeah, as in like you should give them warfarin, but only after you've bridged with low molecular weight heparin in the beginning. Oh, no, not if they're pregnant. There are other agents you can use, but for like a normal, like, I don't know, 50-year-old male who's not going to get pregnant, like, yeah, by all means give him warfarin after you give him low molecular weight heparin. Yeah. Fibrinolytic agents are not indicated for which of the following? D? Someone say D? Yeah, okay, cool. You guys all understand. Do you guys have any other questions you want me to go through? Or anything that was a bit unclear? Yeah. Do you want to come down to the... Yeah, come down to... Yeah. Yeah. Oh, okay, yeah, I know what you mean, but yeah, it will, but it will primarily increase. So it's the same principle as warfarin. So it will increase both because it's affecting the common pathway through factor 10, but it's going to increase APTT more than. Yeah, okay. That was a bit of a bad question. Yeah. So do you guys have any other questions? Cool. Thanks.